Okay, I think we can go ahead and get started. Hi, I'm Jessica. I'm the training director here at CSD, and I'm really excited for our winter quarter lightning talks and poster sessions. We have 5 presenters, well, 4 presenters, 4 posters, but one of the posters is pretty unique in that 2 of our a current fellow and former fellow and current trainee have worked on that together. So they'll both be in the waiting room or in the breakout room to talk to you about that. But we have some great posters. A lot of these are going on to be presented at PAA. So your feedback is really welcome and will really help our students, take their poster to the next level, and maybe we'll bring home another ribbon as CSDE is wont to do at PAA. I want to say a big, before I should have given some announcements first before we get into the lightning talk program. Just for those of you who are curious about next quarter's seminars, we are moving to a hybrid format, though I do know that I also said that at the autumn lightning talks and it did not come to be true. So hopefully it will be this time. So there will be the opportunity for fully in-person attendance and online attendance, and some of our speakers will be both in person and online. And we'll send more information about that as the quarter gets going. We will also, in the first week of the quarter, have a couple sessions of practice talks for our trainees and fellows going on to present oral presentations at PAA. So be on the lookout for that if you want to attend and give our students some feedback. I want to say a huge thank you to our faculty panel. Bettina Shell Duncan, Julie Brines, Jesse Jones-Smith, and Daryl Holman all took a lot of time out of a very busy part of the quarter to give really great feedback on our posters to our presenters. So we're all very excited for you to be here. If you've never attended lightning talks before, one of the most fun parts is that the audience gets to be part of the voting for the best posters. So as the talks come to a close, our short talks come to a close, we will be sharing a link for an online survey where you can vote for your favorite poster and also provide feedback that will be passed on to the students anonymously. And the faculty panel that already reviewed it, they get a little bit more weight in the voting system. So their votes count for 60% and the audience altogether counts for 40%. And so we will announce the winner before we all leave today. We're really happy to have you. And I want to give a big thank you to Courtney Allen, our student organizer of the Lightning Talks, and hand over the program to her.
Jessica. I am sharing my screen. I'm Courtney Allen. Thank you for coming today. Again, just to reiterate, we have these 4 lightning talks today. Each lightning talk will be around 3 minutes. And then after all those conclude, as Jessica said, you'll have the opportunity to join breakout rooms freely. You'll have about 15 to 20 minutes in those breakout rooms. If you'd like to visit all of them, you can. And in those breakout rooms, you can give feedback and praise and critique as you wish to help refine the work that you see here today. Some of these posters will go forward to be presented in conferences, and some are just a short presentation of work that's ongoing. And so all of your time and investment today here is rewarding and valuable for our students. Also, you'll be given plenty of notice in those breakout rooms when we're going to close the voting and come back to the main session. But you can always throw questions in the chat if you have any. So without further ado, I'd like to introduce our first lightning talk presenter, Mita Sahu, who is a doctoral student in the Health Metric Sciences Department. Give me 1 second, I will get this slideshow. Take it away.
Hi, everyone. I'm Mita. I'm a 3rd-year PhD student in Health Metric Sciences. I am excited to present today on subnational HIV spending and the burden of disease in 2 countries in sub-Saharan Africa. This work is still in progress, so I'm definitely happy to take feedback during the poster session. My research question is on how district and county level HIV spending has impacted the burden of disease. So did districts or counties with higher spending actually make greater progress in controlling HIV? And subnational spending in general is really difficult to track. So I reviewed the literature for 43 countries in sub-Saharan Africa to look for spending reports, which had any subnational data. And I only found 2 countries which had spending data available, South Africa and Kenya. And unfortunately, they both only had 2 years of spending data available. So I had to average across the 2 years, and we don't have any time varying spending data. And I then aggregated relevant covariates to the district or county level using publicly available raster data. So population is from the World Pop rasters, modeled HIV prevalence, incidence, and mortality is from IHME, and health facility data is from a geocoded database. And the maps here on the right show district and county level spending per case, with the dots representing the public hospitals, which tend to be in cities or more urban areas. So you can see there does appear to be higher spending per case in more rural areas, which makes sense because the cost to treat someone would be higher in harder to reach areas. I conducted 2 analyses. The first was a linear regression for percentage change in HIV prevalence from 2010 to 2017. We would actually expect funding to be prioritized in places with worse epidemics. So I controlled for baseline HIV prevalence to account for potential reverse causality. And the second analysis was a difference in differences analysis, comparing mortality rates in districts with high and low spending per case, the top and bottom quintiles for each country. Next slide, please. And these are the preliminary results. So in the linear regression, we found that in Kenya, $1,000 of HIV spending was associated with a 14 percentage point reduction in HIV prevalence. So places that spent more did make more progress after adjusting for baseline prevalence, population density, health facilities, and population. And in South Africa, there was no statistically significant association. So yeah, that was interesting. These results were also robust when I ran spatial models, which accounted for the correlation between neighboring districts. And then second, I also ran a difference in differences analysis comparing districts with the highest and lowest spending per capita. And in both countries, there was no statistically significant association with HIV mortality. But one thing is that the difference in differences analysis didn't account for covariates like urbanicity. So the next planned step is to match districts on population density to make sure they're comparable. So overall, the results show that in Kenya, there does seem to be some evidence that districts that spent more have achieved greater progress. But interestingly, we don't see this in South Africa. And obviously, this indicates that more cost-effective programs are essential. And that's it. Thank you for your time.
Mita, moving right along, we next have Nick Irons, a doctoral student in the statistics department.
Should I start talking or sorry?
Sorry, go ahead, Nick.
Oh yeah, okay.
I muted myself.
Can you go to the next title slide? Thank you. So today I'll be talking about optimal control of the impacts of COVID-19 via non-pharmaceutical interventions. This is work that's supported by CSDE and the National Institutes of Child and Health Development. Next slide. So you probably don't need too much of a reminder, but just to set the stage for my work, the impacts of COVID-19 have been widespread and extremely severe, both in terms of public health. So these are old numbers, but as of last month, there were over 75 million reported cases of COVID in the United States, as well as 900,000 or so deaths. And both of those numbers are probably pretty serious undercounts of the true numbers. On the other hand, if you click, we also have effects of COVID that kind of spill over into other domains. So there's been a lot of talk about learning loss due to school closures, as well as other social and economic effects of implementing non-pharmaceutical interventions in response to COVID. So if you can click. So in particular, there's one famous paper, for example, by Larry Summers and Dave Cutler that estimated that that COVID-19 cost $16 trillion across the world. Next slide. And so that kind of introduces this trade-off. You know, there's a trade-off between public health and the socioeconomic impacts of implementing these interventions. And you know, there are also health effects of these these deleterious economic effects too. And so these are things that decision makers have to weigh when they're deciding what policies to implement over time. And the pandemic has posed especially significant challenges to decision makers at every level of government, in particular because there's a lot of uncertainty in some of the key variables that they're dealing with. Click. So they're making difficult real-time decisions with limited data, and this all is occurring among contentious debate about non-pharmaceutical intervention policies that reduce viral transmission but present severe economic and social consequences. So these include non-essential business closures, work closures, school closures, stay-at-home orders, social distancing measures, among other things. And so in my work, in terms of goals and contributions, this is still work in progress, so some of these are still goals. I aim to develop a statistical decision framework based in optimal control theory to address these trade-offs of implementing NPIs. Click. So the goal is to derive optimal non-pharmaceutical intervention policies from the perspective of trying to reduce both public health consequences and economic consequences, and also coming up with a kind of quantitative framework to study this problem will allow me to quantitatively assess the efficacy of policies that have actually already been implemented during the pandemic to see how they performed relative to some other policy choices. And regarding the current literature in this domain, there are a number of pretty serious gaps that we hope to fill that, in my opinion, severely limit its current value in informing and evaluating policies. So in particular, I model multiple specific NPIs calibrated to US state level COVID data. So a lot of prior work models a single like catch-all lockdown NPI, which isn't actually that helpful to policymakers when they're trying to decide, should I close schools this week? Should I keep bars and restaurants open next week? Furthermore, we aim to account for uncertainty in the relevant model parameters to derive robust policies. So in particular, there's a lot of uncertainty, not only in the kind of epidemiological parameters that determine COVID transmission, but also in the costs of these NPIs and their effects. And I have some results on my poster, if you come to the breakout room to check out, demonstrating what can go wrong when you don't actually account for uncertainty in these parameters. So yeah, that's it. Thanks.
Thank you, Nick. Our next presentation will be by Zoe Pleasure, a doctoral student in Health Systems and Population Health Department.
Hi, everyone. My name is Zoe, as Courtney said, and I'm really excited to talk to you all about some of this descriptive work I've been working on for the last year or so with some former colleagues at the Guttmacher Institute about sexually transmitted testing among young people 15 to 24 years old. Some background and motivations for this work is that young adults 15 to 24 acquire almost half of all newly reported STIs. We also have found in previous work that the total number of adolescents receiving STI care has grown during these 2 time periods. And also still little is known at the national level about how many young people receive STI testing, where they go for this care, and what inequities and disparities exist in the delivery of the care. Next, Courtney. Thanks. And some of the aims that we decided to explore were describe and examine differences in patterns of STI testing for sexually active young people, examine differences in response based on question mode in the National Survey of Family Growth, which is the NSFG, and also describe the distribution of those who received STI tests by clinic type and demographics. So like I said, we use the NSFG for this for these analyses, and we pooled survey rounds from 2013 to 2019 to get a big enough adolescent and young adult population. And the outcome measures we looked at were STI tests in the last 12 months and type of clinic visited for the STI test. We limited our sample to all sexually active respondents age 15 and 24, and this was sex with opposite or same-sex partners in the 12 months preceding the NSFG interview. And we used bivariate weighted logistic regression and also chi-squared for descriptive patterns. So some of our very preliminary findings and overview of the findings is that we found that 53% of women and 22% of men received an STI test in the last 12 months. And we found that certain populations were more likely to receive an STI test based on our logistic regression models. And we also found that there is a relative, difference between the female and male reporting of STI tests based on survey mode. So some of you may know that the NSFG has 2 modes of survey delivery. One is where the respondent wears headphones and responds to questions through a prompt, which is audio computer assisted self-interviews. And then also there's this more traditional face-to-face interview that NSFG conducts. So the STI test question is asked in both of these survey modes. So it was interesting to look at on that graph on the left, the difference between the survey modes and look at the difference by sex as well. And then as you can see in the chart on the right, males were more likely to rely on publicly supported clinics for STI care, and also a substantial portion relied on other sources of care, which include hospitals, urgent cares, emergency rooms, pharmacy-based clinics, school-based clinics. So it was interesting to see that comparison between the sexes as well. And then some very overall conclusions. There seems to be low STI testing for this population, and this may be due to CDC guidelines. Currently, only females are recommended to get screened for chlamydia and gonorrhea if they're sexually active each year for this age group. Men are not. So it could possibly be because of these guidelines that we're seeing this difference. There's also seems to be differential testing based on race and ethnicity and insurance status, which could suggest potential provider bias. We also found that there was more reliance on publicly supported clinics for men, and also that these clinics continue to be important sources of care for people of color, those with public insurance and uninsured, and people living in low-income households. So there's many potential system, provider, and individual level explanations for these patterns, and I'm super happy to discuss more about this in the breakout rooms, and also just talk about the NSFG and the limitations of using the NSFG for this question. Yeah, so thank you for listening, and I'm excited to chat more.
Thank you, Zoe. And last but not least, we have a poster represented by 2 students today, Maria Vignau and Osli Noor, but Maria will be giving the lightning talk. So I will pass it over to Maria.
Hello, everyone. So my name is Maria, and I'll be presenting on behalf of Asli Noor, who's the lead author on this paper, and also a team of scholars from the University of Washington and the Max Planck Institute for Demographic Research on our study, which is called The Diffusion of Scientific Knowledge on Family Planning Behavior, When, Where, and by Whom is Research Being Done? And so the background of this project really is how the body of research on family planning behaviors is very heterogeneous in its topics, its conceptual definitions, its methodological approaches. This diversity and abundance has contributed very rich insights for researchers and practitioners in the field. But the accumulation of empirical evidence without some guidance runs the risk of piling up without generating systematically obtained insights. And so what we did, our team, we conducted a scoping review to better understand the state of knowledge in the field. And the research questions that we have for this particular project are: when, where, and by whom is knowledge on family planning being produced, and how are the characteristics of knowledge production associated with higher impact and greater attention from the scientific community. Just very briefly, our data and methods. We limited our search to articles published in English between 2000 and 2016, and we restricted the inclusion of articles to those that focused on FP 2020 countries, where the outcome variable was classified as determinant of use, non-use, or unmet need. And we have here the Prisma diagram of the sort of like inclusion of our articles. And to complement the scoping review data, we then use digital object identifiers of the publications that we selected and metadata on authors, organizations, countries, and impact, which is the citations. I tried to, next slide, please. So I'm just going to present very briefly one piece of our results, which has to do with the composition of the authors. We explored the gender composition and the geographic affiliation of the authors that are publishing in this field. And sort of like our main findings, descriptive findings at this stage is that most research is collaborative. So we found that team of authors had the highest rates of publication across all dimensions of family planning behavior. In terms of gender, we found that articles published by teams of men and women accounted for nearly half of all publications in our database. And in terms of geography, articles published by team of authors from the Global South represented the largest percentage of all publications. And then groups of Global North and Global South authors came as the second most published group. And then the other part of an analysis sort of like focuses on these citation counts. Descriptively, we found that authors affiliated with institutions in the United States showed an extremely high number of citations, and these were followed by Great Britain. But we also found that several countries in the Global South had very high numbers of citations, including Nigeria, Ethiopia, Kenya, India, and Pakistan. Next, so sort of like to leave you wanting with more, come to our poster to find out about the association between citation counts and the author's gender, institutional affiliation, and collaborations. Thank you.
Thank you, everyone. That concludes our lightning talks. We're now going to move on to breakout rooms where you can choose your own breakout room, move around freely until about 1:15. So you do have about 20 minutes. Jessica, sorry, go ahead.
Yeah, I'll pop the link back in the chat one more time. Just remember that when you leave the room, you may not have access to the link anymore. So I really encourage, we can come around to rooms, but I would click on the link now before you leave the main room. So I'll pop that in the chat just now, and I'm going to open the rooms.
Yeah, so I won't be announcing the winner. I'll be introducing our previous winner from the autumn CSD Lightning Talks, Lizzie Pelletier. So Lizzie, if you could announce who you're passing your Lightning Talk crown to, that would be great.
All right, great job, everyone. Really enjoyed the presentations. The winner is Maria Vignau and Asli Noor. Great job.
I would like to follow up though and say that the audience was tied, and we did have to defer to the faculty panel for a very tough tiebreaker.
Congratulations.
So I want to say thank you again to everyone. Congratulations to Maria and Asli. And I know that Maria has brought home a ribbon to CSDE from PAA before, so maybe this will be the second one. And for those of you going to PAA, hopefully y'all can stop by and see Nick and Maria, and I think Zoe is giving an oral presentation, but we'll give more information about all of our student participation. But thank you so much for coming, and thank you again to our faculty panel, Jesse, Bettina, Julie, and Daryl. We really appreciate your time. And thank you so much, Courtney, for all the work you've done this quarter and last to plan this event. Yeah, we'll see you next quarter at hopefully in person or on the screen in person in the Hans Rosling Center. So we'll send out information at the beginning of the quarter about our transition back to a new format for CSDE seminar.